Hi, this video is about the development of cardiovascular system. So these are the learning outcomes where we'll be discussing the steps in the normal development of the heart chambers and the related congenital heart diseases, and also I'll be including the steps for the development of aortic arches. We all know that the heart has for the centuries been a fascination for the anatomist, even the embryologist, biologist and all the physicians, because this is the organ which is the most essential for life, and heart is the first organ to form in an embryo. So we know that heart, the human heart, which is four-chambered, with a pair of valved muscular pumps combined in a single organ. So each pump which has been included has the right and the left side of the heart. They are physiologically separate and they are interposed in series at different points in double circulations. The primordium of the heart and the vascular system, they appear very early at about middle of the third week of intrauterine development. Before that, the embryo will be dependent on the nourishment through diffusion alone. But as the embryo develops, it can't be satisfied with the nourishment on diffusion alone. So, extra circulatory system is necessary for the nourishment. This leads to the development of the heart, which starts at the middle of the third week, and the heart starts functioning at the beginning of fourth week. So as I told earlier, once the heart develops, so this efficient method is very much necessary for acquiring the oxygen and nutrients from the maternal blood, and also for disposing the carbon dioxide and the waste products out from the embryo. So how the heart develops? So the cells that give rise to the heart includes the splanchnic layer of lateral plate mesoderm. So lateral plate mesoderm is a part of the intra-embryonic mesoderm. Once the gastrulation occurs, there will be formation of three layers: ectoderm, intra-embryonic mesoderm and the endoderm, where intra-embryonic mesoderm is further subdivided into paraaxial, intermediate and lateral plate. And lateral plate, due to the development of intraembryonic coelom, there will be formation of somatic layer and splanchnic layer. Okay, so the primary heart field or the heart cells are located in the splanchnic layer of lateral plate mesoderm, which majorly gives contribution for the formation of myoepicardial mantle, okay, which gives rise to the layers called as myocardium, epicardium and the conducting tissues, which includes the SA node, AV node, the bundle of His and the Purkinje fibers. Okay, and also the mesoderm gives contribution for the angioplastic mesenchyme, which gives rise to the endocardium layer or endocardial epithelial layer of the heart. Not only the splanchnic layer, the somatic layer of the lateral plate mesoderm also gives contribution for the formation of pericardium, especially the parietal layer of pericardium. Okay, the visceral layer is also called as epicardium in the heart, which is contributed by the splanchnic layer, but the parietal layer of the pericardium is contributed by the somatic layer of lateral plate mesoderm. So splanchnic and somatic layer are separated by the intraembryonic coelom, which later gives rise to the primary body cavities, and the cavity surrounding the heart forms the pericardial cavity, which is lined internally by the visceral layer of pericardium, which is called as epicardium, and the parietal layer of pericardium. There is also contribution from the extracardiac region, that is mainly from the neural crest cells. So neural crest cells are the specialized cells coming from the neural folds. Okay, so they migrate throughout the body, giving rise to different structure. One of the structure I had told in my earlier video on the development of GIT, it gives contribution for the development of parasympathetic ganglion in the GIT organs. Not only that, neural crest cells is very much necessary for the formation of septum, which differentiates the aorta and the pulmonary area, the pulmonary artery. Okay, and also it gives rise to the tunica media of the great vessels. Okay, so there are different layers in the great vessels: tunica intima, tunica media, and tunica adventitia. So the media layer is mainly contributed from the neural crest cells. So initially, before the third week, when there is two layers, epiblast and hypoblast, so in that period only there will be establishment of cardiogenic field or primordial heart field. So the primordial heart field, that is the cardiac progenerator cells, are mainly situated in the epiblast layer. Epiblast layer is a very important layer which gives rise to all the three layers, that is the ectoderm, mesoderm and the endoderm. So initially, before the gastrulation, the cardiac progenerator cells are present in the epiblast layer. So these epiblast layer are mainly present cranial to the primitive streak. Okay, primitive streak is a very important process which is necessary for the formation of three layers: ectoderm, mesoderm and endoderm. Where the primitive streak is formed, cranial to that area, there will be progenerator cells which give rise to the cardiac part, okay, the heart, developing heart. So these are present at the cranial end of the primitive streak in the epiblast layer. The signals from the node induces to form the heart field, and then once there is movement of the cells during gastrulation, even these progenerator cells, they migrate craniolaterally and get resided in the splanchnic layer of mesoderm. So this is the primitive streak, which is the initial step during gastrulation. So cranial to that part, the epiblast layer, there are some progenerator cells which give rise to the progenerator heart field area. So once the gastrulation occurs, even these cells undergo migration. They migrate craniolaterally on either side, and there will be formation of two heart fields on either side, which gets resided in the splanchnic layer of lateral plate mesoderm. Okay, so this is the heart field. So once this progenerator cells resides in the splanchnic layer of lateral plate mesoderm, the underlying endoderm will induce these heart field to develop into the future the heart. So not only that, it induces these cells to form the endocardial tube. There will be formation of endocardial tube and also other blood vessels. So this is at the splanchnic layer of lateral plate mesoderm. Along with that, the pericardial cavity slowly starts surrounding the heart field, and at the remaining area also there will be formation of blood vessels, that is in the mesenchymal layer, which undergoes growth and sprouting. Process is called as vasculogenesis and angiogenesis. Okay, so this at the splanchnic layer where the cardiac progenerator cells are deposited. So that leads the underlying endoderm will induce, they send signals, and there will be formation of two endocardial tubes, and also there will be formation of myoepicardial mantle. So this is the early development of cardiovascular system, where the mesodermal cells, which will later, there will be primordial vessel formation, okay, which will turn up into hemangioblast, and that will lead into formation of a tube. So this process is called as vasculogenesis, and once the vessel is formed, it will undergo sprouting and branching. So that process is called as angiogenesis. So there will be two processes, vasculo and angiogenesis, which is the early development of the cardiovascular system. So angioblast, the vessel forming cells, they are differentiated from the mesenchyme cells. They undergo branch, which leads to the formation of blood islands throughout the mesenchyme in the embryo, and then they undergo branching and sprouting. The process is called as angiogenesis, and that leads to the vessel formation. So this flow chart also shows the primordial cardiovascular system development. So angioblastic mesenchyme, which are present where the progenitor cells for cardiac development have been deposited. So they aggregate to form the endocardium. They also enclose a cavity, small cavity, and they form the blood islands, and there will be formation of a hollow endocardial tube in the splanchnic layer of lateral plate mesoderm. Okay, so this is the embryo, developing embryo. So this is the primitive streak with the primitive node. At the cranial end you can see the progenitor cells, the cardiac progenitor cells. This undergoes migration and gets resided in the splanchnic layer of mesoderm. So if the section is taken sagittally, so if the section where the both cephalocaudal region has to be seen, if the sagittal section has been taken, so it is seen like this. So cranial to the development of neural fold. So this is the neural plate formation. So cranial most part, this is the area where splanchnic mesoderm are situated. This is before folding occurs. Okay, so here you see the progenitor heart cells, which will form a hollow endocardial tube, horseshoe shaped tube, and it is enclosed by the cavity which later forms the pericardial cavity. So once this is formed, the embryo undergoes folding both at the cephalocaudal region, and it also undergoes lateral folding. So here it is showing the lateral folding of the embryo, and also cephalocaudal region, they undergo folding. So once the folding occurs, the position of the heart field differs. So this is before folding. As I told, this is the developing primordial brain. The neural fold is forming the brain. So cranial to that will be the location. This is before folding. Cranial to that you see the oropharyngeal membrane, which forms the future oral cavity, or the buccopharyngeal membrane. Cranial to that is the position of the heart tube with the pericardial cavity. In between that, the mesenchyme will form the myoepicardial mantle. Okay, so once the folding occurs at the cephalocaudal direction and also on the lateral, so this is after the cephalocaudal folding. So the oropharyngeal membrane comes and lie in the ventral aspect. Before it was cranial to the primordial brain development. After folding, the oropharyngeal membrane is shifted to the ventral aspect, and also the developing heart tube with the pericardial cavity comes and lies at the ventral aspect. So initially it will be at the cervical region. Once the complete heart is developed, the heart undergoes migration. So it migrates caudally and comes and lies at the thoracic region. Okay, so this is before folding, the location, and this is after the folding, where it comes and lies onto the ventral aspect of the developing brain. So here you can see the blood islands have formed, and they have undergone sprouting and branching, and this has led to the formation of heart tube. Okay, and this is the cavity, the body part of the body cavity from the intraembryonic coelom, which later forms which surrounds around the heart tube to form the pericardial cavity. In between that, the layer of mesoderm, they form the myoepicardial mantle, which later give rise to the myocardium and the epicardium of the heart. So these development are induced by the underlying endoderm. So this underlying endoderm, so this endoderm forms the part of the pharyngeal arches or the pharyngeal apparatus. Okay, so the pharyngeal endoderm, due to the induction from the signals from there will be formation of a heart tube surrounded by the myoblast, which give rise to the muscle layer, the myocardium. So this is the position of the heart tube before the formation of head and tail folds, that is the cephalocaudal folding, and this is after the folding, which occurs, which completes at the 4th week. After the folding, the heart tube lengthens and it forms a part of the pericardial cavity. It will be enclosed by the pericardial cavity. Okay, and it starts lengthening both on the cranial aspect and also the caudal aspect. So this lengthening is very much necessary for the further development of the heart. Along with that, there will be migration of the septum transversum. The septum transversum, so this is septum transversum. as I told what is septum transversum in my earlier videos on development of respiratory system and also development of the gastrointestinal system. So septum transversum is a plate of mesoderm which is initially at the cranial most aspect. Okay, so after the folding it comes and lies ventrally, which gives contribution for the development of the diaphragm and also in the development of the mesentery, the ventral mesentery in the GIT system. So this septum transversum also gives a contribution to form a layer around this pericardium called as fibrous pericardium. You had learnt in the gross anatomy of the heart. The heart is surrounded by two pericardium. One is fibrous, which is outermost, then is the serous pericardium. Serous pericardium again has two layers, parietal and visceral layer. Within the serous pericardium there is a serous cavity called as pericardial cavity. Okay, so this fibrous pericardium is contributed from the septum transversum. So I will repeat once again that heart has two pericardium, fibrous and serous pericardium. Fibrous pericardium is contributed from the septum transversum. Then the serous pericardium has two layers. Parietal layer is contributed from the somatic layer of lateral plate mesoderm. Then they have the pericardial cavity. Then the innermost is the visceral layer, which is also called as epicardium, which is contributed from the myoepicardial mantle, which is formed by the myoblasts surrounding around the cardiac myoblasts surrounding around the endocardial hollow tube. So this is a summary of the layers. Endocardium is from the angioblastic mesenchyme, that is the blood vessel forms in the splanchnic mesoderm. There is mainly the cardiac progenerator cells, again which is induced by the underlying endoderm, which leads to formation of angioblastic mesenchyme by process of vasculogenesis and angiogenesis, leads to the formation of endocardial tube, which forms the endocardium. Myocardium and epicardium by the myocardial mantle of splanchnic mesoderm. Then parietal pericardium, which is contributed from the somatopleuric layer of lateral plate mesoderm. Fibrous pericardium is from the mesothelial cells, which mainly arises from the septum transversum. These are the layers of the heart. So once the folding occurs, even by the lateral, as I told, the folding occurs at the head and the tail end and also on the lateral aspect. So once there is folding from the lateral aspect also, the two endocardial tubes which are formed at the either side of the splanchnic layer of lateral plate mesoderm, they fuse to form one single tube, but they are fused only at the cranial aspect, but the lower 1/3, the caudal 1/3 won't be fused, it will be separate. Okay, so which forms the sinus venosus. So initially there will be two endocardial tube at the splanchnic layer of lateral plate mesoderm. Once the lateral folding occurs, the two tubes fuse together. Okay, so which starts from the cranial to caudal end, and the caudal most won't be fused, mainly the cranial part will get fused. And the cranial most part forms the outflow tract, that is the arterial end, which gets connected to the developing dorsal aorta. As I told, the blood islands are not only formed at the heart area, it also forms all over the mesenchyme, where it undergoes vasculogenesis and angiogenesis to form the different blood vessels. And this cranial part gets connected to the vessels which forms the dorsal aorta. So this forms the arterial end of the heart tube, and that is the outflow tract where the blood goes outwards, and the caudal end forms the inflow tract, which is mainly the venous end, which is called as sinus venosus. Arterial end and the venous end. So this is the main subdivision of the heart tube and what it gives rise to, which part of the heart it gives rise to. So once the tube starts lengthening, as I told, there will be adding up of cells, the heart cells, and that mainly from the cranial part, and that leads to the lengthening of the heart tube, which is very much necessary for the further development of the heart. So there will be formation of different dilatation and constriction. So alternate dilatation, there will be constriction, dilatation, constriction. So like that, there will be alternate dilatation and constriction of the heart tube, and there will be different parts which can be named as the cranial most part, which is the outflow tract, which forms the outflow tract, is called as bulbous cordis. Then this is the primitive ventricle. There will be constriction and again dilatation. The next dilatation is called as primitive ventricle, and this constriction is called as, since it is between bulbous area and the ventricle area, so this will be called as bulboventricular sulcus. Then the next dilatation is called the primitive atrium. So the constriction will be called as atrioventricular canal. The next is the sinus venosus. This is the caudal end which forms the inflow tract, which has a body and two horns, the right and the left horn, which receives different veins from the different parts of the body, which includes the cardinal vein, right and left cardinal vein. Then there is right and left umbilical vein, and there is right and left vitelline vein. So these are the three veins which enters the right and left horns of the sinus venosus. So bulbous cordis, bulboventricular sulcus, primitive ventricle, atrioventricular canal, then the primitive atrium, then the sinus venosus, which is this, which has the body, right and the left horn receiving all the veins which carry the blood from the different parts of the body. So this bulbous cordis, due to the addition of the cells, there will be lengthening of the tube, which can be subdivided into three areas. The distal 1/3 is called as truncus arteriosus, which forms the ascending aorta and pulmonary trunk. Then the middle 1/3 forms the conus cordis, which forms the outflow tract of the right and the left ventricle. Okay, then the proximal 1/3 forms the trabeculated part of right ventricle. You will be learning in the gross that ventricle and the atrium will be having the rough part, which is the trabeculated part, and the smooth part. Okay, the trabeculated part of the right ventricle is formed from the proximal 1/3 of bulbous cordis. Okay, then the outflow tract, that is the smooth part of right and left, both right and left, is from the middle 1/3, which is called as conus cordis, and distal 1/3, the truncus arteriosus, gives rise to the two major vessels, that is the ascending aorta and the pulmonary trunk. This is the primitive ventricle. Okay, the complete primitive ventricles give rise to the rough part or the trabeculated part of the left ventricle. So as I told, the rough or the trabeculated part of the right ventricle is formed from the proximal 1/3 of the bulbous cordis. So the primitive ventricle only gives contribution for the left ventricle, that is the rough part of the left ventricle. Then you have the atrium. Okay, the primitive atrium, which subdivides into two and gives rise to the right and left atria. They get partitioned and gives contribution for both right and left atria. And this sinus venosus form the smooth part of the right atrium. Okay, so smooth part of the right atrium is contributed from the body and the two horns of the sinus venosus, and the rough part of right and left atria is from the primitive atrium. So this is the main subdivisions of the heart tube and their fate, which give rise to different parts of the heart. So due to the lengthening of the heart tube, since the space is less, it undergoes looping. Okay, so there will be formation of cardiac loop in order to increase in size within the limited space. So due to the lengthening, so there will be formation of a loop of the heart tube, which is called as cardiac looping. So this lengthening and cardiac looping is very much important in the steps of development of heart. because once the looping occurs, so the heart occupies the left side of the thoracic cavity. Okay, so what happens? So this is the heart tube. As I told, the caudal end, they bend, they form a U-shaped loop, they bend towards the left side, and slowly they occupy the dorsal aspect, that is behind the posterior aspect, the dorsal aspect of the arterial end, and they also move towards cranial aspect. Okay, so initially it will be caudal. Once the U-shaped loop is formed, they undergo dorsocranial looping, and this junction, the bulboconus junction, will be on the right side initially. Slowly they move towards medial aspect and they come and lie in the midline, so that the two atria occupies on either side of this loop, either side of this tube. So this is the truncus arteriosus, conus cordis. Okay, this is the distal 1/3, this is the distal 1/3, middle 1/3, and this is the proximal 1/3, which is the primitive right ventricle, the rough part. Then this is the primitive ventricle, which gives rise to the left ventricle, and these two are the atria, which will then expand laterally to give rise to, and they are separated to form the right and the left atrium. So because the bulbus cordis and ventricle grow faster, as I told, the lengthening occurs more towards the cranial aspect. So the heart bends to the right, forming a U shape. So the cranial part of this tube, they move towards right side, and the caudal part will move towards the left side. So this leads to the formation of a U-shaped loop. So the cranial part moves towards the right side, and the caudal part, they bend and move towards the left side of the thoracic region. So they form a U-shaped bulboventricular loop, and there will be sulcus. The sulcus will be exactly at the center. So this is the bulboventricular sulcus, which you can see here. This is the constriction between the proximal 1/3 of the bulbus cordis and the primitive ventricle part. So that is the sulcus. Okay, so initially the cranial part of the tube will be on the right side of the thoracic region, and this will be on the left side. Okay, once the sulcus is formed, so this tube slowly moves medially and comes lie in the midline, and there will be lateral bulging of the primitive atrium, which gets partitioned later to form the primitive left atrium and the primitive right atrium. So as the primordial heart tube bends, the atrium and the sinus venosus come to lie dorsal to the truncus arteriosus and conus cordis, and also the ventricle. So that's why I had told that the caudal end of the tube, that is the sinus venosus and the atrium, they bend towards the left side, come and lie dorsocranial to the truncus arteriosus and the conus cordis. So this is how the looping takes place, and which is one of the most important step in the development of the heart. So the clinical application in relation to the cardiac loop, if the cardiac looping occurs in the opposite direction. Okay, so what happens? Heart lies on the right side of the thorax instead of left side. So here, this is the normal looping where the heart is located. You can see it is more towards the left side. You can feel the apex beat of the heart more towards the left hand side. Okay, but if the looping occurs into the opposite direction, where the caudal end of the heart tube moves towards the right side of the thorax, so that condition is called as dextrocardia. Okay, so heart lies on the right side of the thorax instead of left side. So here in this picture, this is showing the normal looping of the cardiac tube, and this is the looping which occurs in the opposite direction, that is dextrocardia. So heart loops to the left instead of right. This is why they are telling left if you see from the front. So if you see from the front, so this will be left, this side will be the left, and this side will be the right if you are seeing from the front. So that's why they are explaining in that way. Okay, but if you compare to your body, the looping will be in the opposite direction. So either you can remember it as, if you see from the front, the normal looping occurs to the right side of the heart. So this is the right side of the heart and this is the left side if you are seeing from the front. Okay, so if the looping occurs to the opposite direction, the heart looping to the left instead of right, so that leads to dextrocardia. So this dextrocardia is only related to the heart, where the heart is positioned on the opposite direction. Okay, sometimes this dextrocardia can coincide with a condition called as situs inversus. So situs inversus is a condition where the major organs, which includes the liver, spleen, cecum, all those will be situated on the opposite direction. So we know that liver is situated on the right side, the right hypochondriac region, spleen at the left hypochondriac region. But here in situs inversus, all the major organs including the heart will be in a reverse direction. So heart will be on the right side, okay, the left, that is the apex beat can be heard on the left side of the thorax, right side of the thorax. Okay, liver will be situated in the left hypochondriac region, then spleen on the right hypochondriac region. Cecum can also be seen on the left iliac fossa, the iliac region. So here the major organs will be at the opposite side of the abdominal cavity and even in the thoracic cavity. So this condition where the major organs, which includes liver, spleen, cecum, appendix and the heart, so that condition is called as situs inversus. But if there is only location of only the heart, but other organs like liver, spleen and cecum are in the normal position, but only if heart is positioned at the opposite direction, then that condition is called as dextrocardia. But if it is coincided with other major organs, then it will be called as situs inversus. So situs inversus are seen in many of the celebrities. She is Catherine, who had played a mother role in Home Alone. You all know that. And he's a famous basketball player who have situs inversus. So the individuals who have situs inversus can lead a normal lifestyle without any, sometimes they won't be knowing that their major organs are they are placed opposite. Okay, so they can lead a normal lifestyle. It is not very harmful for the body. So here it is showing the picture of situs inversus, where you can see the heart looping has occurred in the opposite direction and the apex of the heart is situated on the right side, and the liver, you can see it is situated on the left hand side, the left part of the abdominal cavity. So this is an X-ray picture showing the situs in dextrocardia. Okay, so this is the normal radiograph, chest radiograph, and here this radiograph is showing the dextrocardia. Now coming to the development of sinus venosus. Sinus venosus is the venous end of the heart tube which receives venous blood from right and left sinus horns. So this is the right and left sinus horns receiving blood, one from the cardinal veins. Okay, so it has anterior cardinal vein, posterior cardinal, both joining to form common cardinal vein, which receives venous blood throughout the body parts. Then you have the umbilical vein, which receives blood from the placenta. Then there is vitelline vein, where the blood is received from the yolk sac. So these are the three veins which enters the right and left side of the sinus horns and forms the sinus venosus. So vitelline vein, also called as omphallomesenteric vein, receives venous blood from the yolk sac. Umbilical vein from the placenta, from the maternal side. Then the common cardinal vein, which has two branches, anterior and posterior cardinal vein, which receives blood from the other parts of the body. So initially when the sinus, the opening, the communication of the sinus venosus into the atrium will be wider. You can see here, this opening is called as, the communication is called as sinoatrial orifice. Okay, so initially the communication will be wider between the sinus and the atrium. Okay, so as the development goes on, at around 4th to 5th week, there will be obliteration of two veins. One is right umbilical vein and other is the left vitelline vein. So due to the obliteration of right umbilical and the left vitelline vein, the left sinus horn loses its importance and the entrance, that is the sinoatrial orifice, slowly shifts towards the right side. So you can see here, initially during the 4th week, the sinoatrial orifice is equal and it is wide open. So at around between, that is 4th to 5th week, exactly at 5th week, there will be obliteration of right umbilical vein and the left vitelline vein, and the left horn loses its importance slowly and the entrance slowly shifts towards the right side. So there will be complete obliteration of the left sinus horn at around 10th week once the left common cardinal vein obliterates. So once again I repeat, at the 5th week there will be obliteration of right umbilical vein and left vitelline vein. At around 10th week there will be obliteration of left common cardinal vein. So all that remains on the left sinus horn is the oblique vein of left atrium and coronary sinus. So you had learned in the gross anatomy that right atrium has the opening of coronary sinus. Coronary sinus is the venous chamber which receives vein from the heart. Okay, so that is derived from left horn of sinus venosus. So all that remains once there is obliteration at 10th week, there will be obliteration of left common cardinal vein at 10th week and obliteration of left vitelline vein at 5th week. So all that remains of the left sinus horn is the oblique vein of left atrium and coronary sinus, and there will be complete shift. So the only communication that between the sinus venosus and the atrium is through right horn of sinus venosus. Okay, so this is the sinoatrial orifice. So the only communication is through right horn. So the sinoatrial orifice will completely shift towards the right atrium. So you know that, as I told earlier, the primitive atrium will divide into two parts, giving rise to right atrium and left atrium. So the sinoatrial orifice completely move towards the right side of the atrium. So 5th week, obliteration of right umbilical vein, left vitelline vein, left sinus horn loses its importance, and all that remains from the left sinus horn, which will give rise to oblique vein of left atrium and the coronary sinus after the obliteration of common cardinal vein, left common cardinal vein at around 10th week. So once there is complete obliteration, so the right sinus horn and veins enlarge greatly and slowly it gets incorporated into the right atrium. So this is the primitive atrium. So this is the right atrium. So completely they get incorporated into the right atrium, which forms a smooth wall part of the right atrium. So I had told earlier, each atrium has the rough part, that is the trabeculated part, and the smooth part. The smooth part of the right atrium develops from the sinus venosus, that is mainly the right horn of the sinus venosus. So right half of the primitive atrium forms the rough part of the atrium, that is the trabeculated part. Body and the right horn of sinus venosus forms the smooth part of the atrium. Okay, then the right half of the AV valve, that is the right atrioventricular valve, forms the right atrioventricular orifice. So once this valve, you can see here, this is the sinoatrial orifice. So it is flanked by two valves. One is the right venous valve and the other is the left venous valve, and dorsocranially they are fused to form septum spurium. So you can see here, this is the right venous valve, this is the left venous valve. So they are dorsocranially fused to form septum spurium. So as the development goes on, the septum spurium and the left venous valve get incorporated in the formation of the interatrial septum. So okay, they get incorporated for the development of interatrial septum. The superior part of the right venous valve, they get obliterated. Okay, and the inferior part mainly contributes for the formation of valve of inferior vena cava and valve of coronary sinus. So you can see here the inferior part of the right venous valve, they mainly contributes for the formation of valve of inferior vena cava and valve of coronary sinus. Okay, so about the atrioventricular orifice, I will talk it later. Okay, further we'll go on, we will talk about it later. So this you have to remember, which part of the atrium is derived from which embryological structure. So now coming to the formation of the left atrium, again the left half of the primitive atrium, as I told, primitive atrium gives rise to both the rough part of right and left atrium. So the left half of the primitive atrium forms the rough part of the atrium, and the pulmonary veins which are formed, okay, so they get absorbed. Initially there will be single vein, later they form 4 veins. Okay, so they get absorbed and they form the smooth part of the left atrium. Okay, so initially it will be single, later it divides into 4 pulmonary veins. So they get absorbed and they form the major part, the smooth part, and the rough part is from the left half of the primitive atrium.